So, good evening, and I hope everyone is doing fine and is healthy. I, Dr. Dushyandal, on behalf of Abbott Primary Care General Medicine Division, welcome you all for this academic feast. We at Abbott believe that continuous medical education and knowledge sharing is definitely going to improve patient outcome, and continuing our endeavors to achieve it, we have planned this very important webinar on a very pertinent subject today. At the outset, I would like to thank ICS, Indian Chess Society, for guiding and for supporting us in drafting and in planning this particular webinar. And a series of webinar is happening. Last Friday, we had one webinar. Now, coming Friday, we also have one webinar. So we would be looking forward for your presence there also. And the webinar is on a very pertinent and relevant topic in the today's era, that is COVID-19. So just a second. The topic of today's webinar is implication of rising burden and a focus on management of mild to moderate COVID-19. So post March 2020, when WHO declared it as a pandemic, COVID-19 has increased in leaps and bounds and is still evolving in a very huge intensity. And this intensity, if we see in last 14 days, if I can able to gather, almost around 95 to 97,000 cases are being reported daily from different parts of India, taking the toll to almost more than now 5 million cases. And India stands at number two if we look at the global cases of COVID-19. And this whole pandemic has created a significant impact on the healthcare infrastructure and has posed a great burden on the healthcare warriors, or I would say healthcare providers. With and most of these cases, if you see, almost 80% of these cases are from mild to moderate severity and could be managed at home care settings, at OPD settings with remote monitoring from the treating physicians. So to throw more light on this without causing a further ado, I would like to introduce you to the esteemed panelists of the day. We have with us this would be the agenda. Dr. DJ Christopher, who is going to talk on understanding transmission dynamics for prevention of spread of COVID-19. Welcome, sir. Then we have Dr. Arjun Khanna with us, appropriate settings for home care and protecting household contexts. And finally, wrapping up the show would be Dr. GC Khilnani from Delhi. He's going to talk about medical treatments for mild to moderate COVID-19. So, without taking much time, I would like to just give a short brief about our three panelists today. So, Dr. DJ Christopher is going to moderate the webinar and is going to talk on the dynamics of understanding the dynamics of transmission. Sorry, and he is the president of Indian Chess Society. Hails from Vellore, where he is a professor of pulmonary medicine and associate director at CMC Vellore. He also is a course director for Allergy and Asthma Distance Education Program. Sir has been awarded multiple accolades and is being editorial on the editorial board of multiple high impact factor journals. Welcome, sir. With him, we have Dr. GC Khilnani, a very renowned figure in field of pulmonary medicine. Sir is an ex-HOD and professor of Department of Pulmonary Medicine and Sleep Disorders, AIIMS, New Delhi. Is being a office bearer for multiple uh, societies in India. Is being a member of governing body Indian Chess Society. He's been a member of Executive Council, Indian Society of Critical Care Medicine, and is being coming with a lot of experience in treating patients of COVID-19, and is currently working as a chairman of PSRI Institute of Pulmonary Critical Care and Sleep Medicine. So I welcome you, sir. And with them, we have a very young, dynamic pulmonary specialist, Dr. Arjun Khanna, senior consultant, pulmonary and critical care medicine, Yashoda Super Specialty Hospital, Koshambi, ex-assistant professor from AIIMS New Delhi, having multiple publications and chapters in renowned books, and he's been awarded Global Rising Star in Pulmonology, Lung Health Forum, NICE, France in 2019. So it is an indeed pleasure to have all three of you, and I would now request Dr. DJ Christopher to take the session ahead and enlighten the live audiences with his talk. Over to you, sir.
Thanks very much for those kind words of introduction. Today we are going to talk about home care of COPD of COVID-19 subjects. And in particular, we are going to look at the management of moderate and severe COVID-19 disease. And I'm going to speak to you about the transmission dynamics of SARS-CoV. And this is key for us both to treat patients, especially when they are at home, as well as how to ensure that community transmission is limited to the minimum. We all know that this issue started in Wuhan, which is a large and crowded metropolis with connections to every part of the globe. Because of its size and because it's a manufacturing hub, it had huge economic clout, which meant that a lot of why the virus burst throughout China and then to Europe, then to the Americas. And it has also made its way to the rest of Asia, including us. This is data from about a week ago. I did not even bother to update it because the numbers are high and they keep going up. Globally, at that point, there were more than 66 million cases and more than 800,000 deaths. And India has now reached the second highest in terms of total cases and has started reporting the highest number of cases. Very soon, we may be reporting more than 1 lakh cases a day. This plot tells us where we stand in comparison to some of the other countries with high COVID burden. And the thick line that you see here is the trajectory of India. And you can see that right from the beginning, Indian trajectory has been steadily climbing and it continues to climb. And it has overtaken US and Brazil as the country with the highest incidence on a daily basis. In addition to this, we are concerned about reports such as COVID deaths get underreported. This is the perception of many healthcare practitioners that in fact they encounter more deaths than they read about in the newspapers. In terms of controlling the pandemic, comes from our experience with Spanish flu in the year 2018 to 2019. Then the social distancing measures were tried for the first time. What happened was in Philadelphia, the first case was reported in September 17th, and on October 3rd, social distancing interventions were put in place. And this delay, although about 2 weeks, cost them very dearly. And you can see how the pandemic has soared, and there are huge numbers of and reported its first case later. And by then they had learned from Philadelphia. And so this is the time they reported the first case, which was the 5th of October. And by 7th of October, they already put in social distancing measures. And so they were able to flatten the trajectory. This is how their case numbers rose. And in fact, there's a second bump. But all along, they were able to keep the number of cases within the limits where the healthcare system could cope. And that also is the goal today in ensuring that the healthcare system is not overwhelmed. When we instituted a lockdown in the country, the expectations were that we could sustain lockdown till the cases are on the decline. We could ramp up testing, tracking, and isolation, and healthcare preparedness in terms of increasing bed capacity, increasing ICU and ventilator capacity, and redeployment of healthcare workers could all happen while this lockdown is still in effect. This is how the lockdown actually panned out. If you look at the trajectory of various European countries, and let's look at Germany here. Germany was on the upslope when they instituted lockdown. And during lockdown, the peak occurred, and they were on the way down when they released the lockdown. Likewise, Spain. This is when the lockdown was instituted, and the rise happened mostly after that. And it started declining, and then the lockdown was released. And so with Italy and also with UK. If you look at the Indian trajectory, this is when the lockdown was instituted very early, I think earlier than most of the countries. However, the lockdown has been released when we are still on the upslope and our case numbers are still climbing. So there is no doubt that our case numbers will continue to climb, and there will be a lot more cases reported in our country, and therefore, consequently, a lot more mortality. So there are some ground realities which make fighting a pandemic very challenging. 176 million people still live on less than $2, 140 rupees. And 1% of our GDP is spent on public health care, whereas China spends $398 on a per person on healthcare. India spends $63 per person. So there is a huge difference in terms of healthcare allocation, and that will cost India dearly during the pandemic. There's another concept I want all of us to understand. We read much about what is called herd immunity, and we are all made to believe that the community should reach the herd immunity status before the pandemic will come under control. What is herd immunity? The principle is that enough people in a community should have developed protection. How would they develop protection? Either by being infected or by being vaccinated. As we speak, there is no vaccine. When enough people are protected in the community, they then will not transmit infection to others. By reducing the number of people who can transmit infection in the community, it will be possible to slow down the pandemic to a point when the vulnerable people will have lesser chance of being infected. So who are these vulnerable people? The elderly, those suffering from immunosuppressive diseases like cancer, HIV, those on immunosuppressive medication, babies, maybe even before they can mount their immune responses, people with vaccine allergies, and so on. It is strongly believed that 60 to 70% of the population should be immune before herd immunity develops. In the absence of a vaccine, that means that 60 to 70% should get infected before we can expect herd immunity to kick in, and therefore the pandemic to decelerate and hopefully even stop. What is the actual picture at ground zero? This is data from Delhi published on 21st July 2020. This is a seroprevalence study, and this covered several blocks in Delhi, and you see here the prevalence of seropositivity. I want to remind you that Delhi had a huge number of cases prior to this, and I think now it is on the downslope, although it's not declined dramatically. It is in the background of this that we have to interpret this information. Overall, 8 out of 11 districts had more than 20% seroprevalence. This is 6 months into the epidemic. So 23% of the people at an average were perhaps infected 6 months after this epidemic set in, which means 77% are still vulnerable, which also means that it is not yet time to relax the non-pharmacologic interventions that are in place, such as physical distancing, use of face masks, hand hygiene, cough etiquette, and so on. Therefore, my my understanding of the situation is that this problem is unlikely to go away very soon. A lot of lessons were learned early in the pandemic. I want to take you through what happened with Diamond Princess cruise ship, where 3,700 passengers and crew uh, were traveling, and on the 25th of January 2020, a symptomatic passenger departed and was diagnosed to have COVID-19. On the 3rd of February, the ship was quarantined. Initially symptomatic, then their contacts were tested. Finally, uh, 712, which is 19.2% of the people on the ship turned positive. Of these 712, 331, which is 46.5%, were asymptomatic at the time of testing. And on follow-up, some of them became symptomatic. Modeling estimates put the true prevalence of asymptomatic cases who never developed symptoms to about 18%. What is the transmissibility of the SARS-CoV-2 virus? It is easily transmitted, as we saw in this ship and in several other scenarios. And it is estimated that what is called R0, which is the number of people a single case will infect without interventions, is 2 to 3. The contagiousness is highest around the onset of symptoms and the viral shedding highest in the first 3 days. Transmission can occur from symptomatic and pre-symptomatic patients. This is a very important learning of the virus during this pandemic. And this is what makes it really lethal. And it makes it difficult to isolate people who are causing infection in the community. And that is why this infection is so able to sustain itself. We also know that there are transmission amplifying situations, such as, of course, cruise ship. We talked about long-term care facilities, prisons, sports venues, food processing units, community events, churches, nightclubs, religious gatherings, healthcare facilities, of course, is important. And thankfully, so far, we have not seen such transmission in schools and in educational institutions. We cannot now presume they are safe because they have largely remained shut throughout the globe after the onset of pandemic. So time will tell if these also turn out to be situations where transmissions would be high. What are the modes of transmission? Droplet is probably the best described. Aerosol. Aerosols are viable up to 3 hours in the air. These are small particles, and the virus can move around in the air and remain suspended for a long time, much after the person has left the place. Airborne transmission is talked about. I'm not going to talk about it because we do not know how much this is a factor. Fomite transmission, that the infectious particles can lodge on objects and then by touch, they can spread to other people. Fecal isolation is a factor. Blood 1 to 22%, urine 0. For practical purposes, we can exclude fecal spread, blood and urine spreads. So we can largely stick to airborne transmission and by fomite transmission. This is a picture that illustrates the safe distance with regard to transmission by inhalation. A distance of 6 feet or 2 meters is supposed to be safe, and this is just demonstrating that, because the respiratory droplets from the case will fall somewhere within this range and it would not carry beyond this. These particles actually have to be inhaled by another person for infection to be transmitted. And so with this kind of distancing, it should be possible to limit the spread to a large degree. Transmission occurs much more vigorously with coughing and sneezing. And this is a picture that has been taken with an individual sneezing. And it has been estimated that the spread can be between 23 to 27 feet. 23 to 27 feet. And this is how this is demonstrated. So while droplets would be restricted to the 6 feet diameter, coughing and sneezing can actually take it really, really far. Now, can masks help? 111 subjects with more than one respiratory virus isolated by RT-PCR were studied. 17 had seasonal coronavirus, not SARS-CoV-2, but the coronavirus which was seasonal even before SARS-CoV-2 caused this pandemic. 43 had influenza and 54 rhinovirus. 30-minute exhale breath collection was made with and without a surgical mask. And a bioaerosol collection device captured exhale breath particles. And this is what they found. With coronavirus, the recovery of respiratory droplets was 3 out of 10, as you see here, and 4 out of 10, 3 out of 10 with here and 4 out of 10 with aerosols. So droplets 3 out of 10, 4 out of 10 with aerosols. But when a mask was used, no infectious droplets were trapped, no aerosols were also demonstrated. So it appears that mask is an effective filter and will reduce infection. And this is now well established, and this statement, face mask reduce respiratory virus shedding in exhale breath, is quoted from Nature Medicine. And we all agree that this is in fact absolutely true. And in hospitals, the chance of spreading is even more than in the community. And we know in the hospitals that standard surgical masks is sufficient unless we are exposed to aerosolizing procedures. And so use of mask is crucial, not only for medical personnel, but also for patients and accompanying family members. So it should be hospital policy to ensure that every one of them inside the hospital premises is masked. This is a picture that depicts transmission. So the top picture that we see here is an individual coughing infectious material without a face mask. And you can see huge numbers of infectious material. And the person sitting across does not have a mask. And the risk of infection is very high. And the second picture shows the individual without the mask, but the individual across wearing a mask. And the risk of transmission to him is still high. The third picture shows the individual with a mask, and you can see how the infectious particles very dramatically reduce. And even though the individual does not wear a mask, the risk is medium. In the last case, the individual wears a mask and the individual across also wears a mask, and the risk here is the lowest. And this is the basis of our practice. Now, while it is clear that using mask prevents transmission from the patient who is infectious to others, is there evidence that mask wearers also benefit? So in this case, my question is, are mask wearers less likely to get severe COVID-19 disease? Evidence towards this has emerged, and this is important information that I want to share with you. The concept of viral dose being related to disease severity has been around for almost a century in animal studies, which means that if an animal is exposed to a higher load of the virus, it not only catches the infection more readily, but also develops severe infection. In contrast to an animal published that the viral dose was related to disease severity in hamsters exposed to coronavirus. Hamsters who were given a higher dose got sicker than hamsters that got a lower dose. And in 2015, researchers tested this concept in human volunteers using non lethal flu virus and found the same result. So, the viral inoculum or dose is related to severity. High exposure dose affects tissues more extensively and overwhelms the immune response. It also leads to triggering of immune reactions to contain the infection, which also may cause damage to the body. We today hear about the cytokine storm, which is responsible for extensive lung damage and therefore hypoxia and patients requiring ventilation and so on. Let's talk about fobite transmission. So this experiment was published in the New England Journal of Medicine. It looked at how long the SARS-CoV virus remains viable in different surfaces. So this is the time period where it is viable, first with plastics. With plastics, SARS-CoV remained viable for little over 48 hours. With stainless steel, it was better, about 36 hours. With cardboard, it was 24 hours. And with copper, it was only 8 hours. Now, if aerosolization occurs, they remain suspended for at least 3 hours. So this is the information we need to keep in mind to understand transmission. I want to show you some new data published from Massachusetts looking at pediatric SARS-CoV-2. They studied 192 children with a mean age of 10. 49 children, 26%, were diagnosed with SARS-CoV-2 infection, and an additional 18 met criteria for inflammatory syndrome. 25 or 51% of the children with SARS-CoV infection presented with fever, which means 49% did not have fever. And this is not a rare phenomenon with regard to SARS-CoV-2 in adults, and certainly not rare in children as well. Symptoms of SARS-CoV-2 infection, if present, were non-specific. Nasopharyngeal viral load in these children were highest in the first 2 days of symptoms. The viral load was significantly higher than hospitalized adults with severe disease. How did they compare this? They went and sampled patients admitted to the critical care of the hospital, and arguably they are the ones with the most severe disease. And the viral load in children was significantly higher than the very sick adults. So age did not impact viral load. So children did have a high viral load, but they had lower expressions of ACE2 receptor. The ACE2 receptor is the key to the human body for the SARS-CoV virus. And because of this, children have a reduced predilection for infection and probably have less severe infection. And also, they concluded that children have lower numbers of immune receptors than adults, which makes them less likely to become infected or seriously ill. However, this does not correlate with decreased viral load. And the authors concluded that children can carry a high viral load and are more contagious regardless of their susceptibility to developing COVID-19 infection. What is the take-home message? Kids are possible sources of spreading this virus, and this should be taken into account, especially when we plan reopening schools. They could become the ones that transmit infection into the community, although many of them may not themselves develop any symptoms. I want to conclude. We are in the midst of a pandemic, and probably none of us in our professional life have encountered anything like this. The pandemic has not peaked in most parts of the country, and we have a long way to go. This is a highly transmissible disease, and airborne transmission is the most important. Social distancing and masking are crucial to control the pandemic. Children have mild disease but may harbor a huge load of the virus.
So thank you, Dr. Christopher, for that enlightening talk, sir. I would just request you to take the session ahead, sir. Dr. Christopher, sir, you have to unmute yourself, sir.
Thank you, Dr. Dushyant. I want to invite Dr. Arjun Khanna to give the next lecture. He has already been introduced. Please go ahead, Arjun.
Do you help me when sharing the screen? Yeah.
Yeah, hello doctor. Yes, your screen is shared. Now you can open the presentation, sir. Dr. Khanna, we are
Yeah.
able to
Can
see
you see
your...
it?
Not yet, doctor. We are not able to see your presentation. So share it once again.
Just a second. Yeah, it's showing that it's sharing. I'll share it again. Can you see it now?
Yes, your screen is shared. Yes, perfect. Put it to slideshow.
Yeah, yeah. Good to go? You can
Yes,
see it
doctor.
now?
We can begin. Yes, we can begin, doctor.
Yes, sir.
Sure.
You can begin.
So at the outset, let me thank Dr. Christopher for giving me this opportunity to speak on this very relevant topic. And as Sir has very rightly highlighted that, the COVID pandemic has just begun. And we are just starting to, experience the real ill effects of this pandemic. All our hospital beds are full. There's a fight going on for hospital beds right now in the hospital where I work. So the next topic is very, very relevant. It's very pertinent to how we manage our patients with COVID. I'll be talking in the next 15-20 minutes about the appropriate settings for home care and protecting the household contacts. So what we'll be doing today is I'll be answering these few questions, which would include why home care at all, who is an appropriate candidate for home care, what are the adequate settings for home care, what is the monitoring and treatment to be provided to patients, for home care, and what are the common questions that patients ask us and how do we answer these questions? How do you manage waste at home? What is the prophylaxis to be given in contacts who come in contact, who are taking care of patients who are given home care? Till when should we continue isolations? And then a few practical considerations in India. So the first question that we need to understand is why home care? And as Sir has already, said, this is from the Times of India a couple of days back. India is on the trajectory of rise. We are probably one of the countries in the world where the increase in the number of cases is maximum. Very recently, we touched the 50 lakh mark. And of this an increase in 10 lakhs was seen only in the last 10 to 11 days. So the disease has actually picked up the real momentum now. And in a few days, the disease is going to increase by leaps and bounds, and there is not much, that we can do about it. Now, let us look at, the situation of Delhi and NCR. This is from Delhi Fights Corona website, and the population of Delhi and NCR, combining both the NCR and Delhi region, is approximately 5 crores. Approximately, we are getting around 4,000 cases per day. And if you look at the number of hospital beds which were vacant yesterday, was around 9,000. Now, if Delhi NCR has only 9,000 vacant beds, and the number of cases that we are getting per day is now touching around 4,000, if everyone is admitted to the hospital, we would really have no beds available within 1 or 2 days. Everything is going to get filled up. So that is why home care in COVID is very, very important. And we must, rationalize our resources so that the sickest patients who actually need hospitalization, we are able to give them hospital beds. So there's this WHO program, there's this WHO paper which came on August 2020, 12th August. And this gives us a basic framework of patients, of how we need to manage patients who are suspected or confirmed COVID, and how do we manage their contacts in the home settings. And a lot of what I'm going to be saying, in this presentation is taken from this paper. It is freely available online and everyone can download it. It's a very nice read. So the second question that we need to answer now is, who is an appropriate candidate for home care? Well, as we all know, home care based, management of patients of COVID is not for everyone. It has to be a case-by-case approach. And it is also, relevant for discharged patients. So patients who have been discharged from the hospital but are still COVID positive, we need to extend the same umbrella of home care for these patients. So at the baseline, whenever you are selecting a patient for home care management, you need to look at the risk factors which would be there in a particular patient for worsening of the disease, the age of the patient, social factors, economic factors, where the patient lives, how far he's from the hospital, how intelligent he is, what kind of social support he has, when he falls ill, whether he would be able to come to you, the severity of the disease. Obviously, patients who have moderate disease or patients who have severe disease, you should be admitting them in the hospital. And very, very importantly, because there are local rules and laws, and every state in India has their own rules when it comes to COVID-19, you must follow the local rules and laws. And this is absolutely essential, because at times what the WHO says might not be valid for your state. So every time you send a patient on home isolation, please make sure that you are following the laws of your state. I practice, my hospital is in Uttar Pradesh. So I'll be telling you what we do in our state for these patients. So the crux of COVID home care is, you need to do a thorough clinical evaluation the first time a patient comes to you. The patient who is being subjected to COVID home care, we should be able to monitor this patient. There has to be a channel of monitoring open between you and the patient. And of course, you need to evaluate the home care of the patient. The home setting of the patient has to be evaluated. Otherwise, the COVID home care is not going to be successful if these three parameters are not met properly. So when a patient comes to you for the first time and you are evaluating him for home care, the first things that you need to see in the clinical evaluation are if the patient requires any supportive care. If the patient requires oxygenation, if the patient is dehydrated, the patient requires fluids. If the patient is not looking good, the patient requires extensive monitoring, then obviously the patient is not a candidate for home care. Even if the patient is stable, the patient is not all that symptomatic, but if the patient has risk factors for severe disease, which include an age more than 60 years, the patient is morbidly obese, the patient has any of the chronic non-communicable diseases, particularly those patients who have uncontrolled disease, whether it is chronic heart failure, diabetes, chronic lung disease, chronic kidney disease, or if the patient is immunosuppressed due to any reason, or if the patient has an underlying malignancy. So these patients, even if they come to you in a stable condition, be very careful, because a lot of these patients can actually dip during the course of their home care, and these patients might actually require hospital care. So even if the patient is stable to begin with, you need to be super careful while sending these patients home for home-based management. Then there are shades of gray. If you have a patient who's young, who's otherwise healthy, is asymptomatic, the patient is looking okay, the lab parameters are fine, well, it's an easy decision for home care. However, if the patient has signs of moderate illness, wherein you have signs of pneumonia, which can include fever, cough, dyspnea, fast breathing, but then there are no signs of severe pneumonia, you're not very sure whether this patient is actually going to go down. At presentation, the patient has mild to moderate illness, the saturation is being maintained, the patient is not too dyspneic. On the other hand, you might have a patient who's clinically stable, but the lab parameters are bad. The CRP values are very high, the D dimers are high, the patient is showing bad neutrophil lymphocyte ratios. So, either of the two situations, it is always better to err on the side of safety. And if you have a hospital bed and if you think that this patient can dip, even if the patient has mild to moderate disease to begin with, it is always better to give them hospital-based care. So, a patient who comes to me who is asymptomatic, has mild or moderate disease, but does not have risk factors for poor outcome, I would choose this kind of a patient for providing home care, provided two requirements are fulfilled. Number one, there has to be conditions, which are meant for implementing appropriate infection and control practices at home are met. And you're able to closely monitor these patients for any signs and symptoms of deterioration in their health, either by a trained healthcare worker or a family member. This has to be there. So, patient should have only mild to moderate disease. If the patient has moderate disease, the patient should not have risk factors. And if you are sending this patient home, make sure that there are adequate amenities for infection prevention and control, and someone is able to monitor them at home. Only then COVID home care is feasible. So as per the WHO guidelines, a trained healthcare worker should assess whether the home in question is suitable for isolation. However, this is not, always possible in the Indian settings. A lot of our state governments are trying very hard to send trained healthcare workers to every possible house where there are COVID patients. But unfortunately, the case burden is so high that we cannot expect that the government would be able to send a trained healthcare worker to every house. And when you are evaluating the home care settings, you need to make sure that the family would be able to adhere to the required rules. They'll be able to take care of the hand and respiratory hygiene. They'll be able to take care of the waste management. They'll be able to restrict movement. Otherwise, the home care facility, the home care management of these patients is not going to be successful. So, when it comes to India, it's easier said than done. Because this picture is from a slum which is very near my hospital, and this area has been sealed 2-3 times now, and we get a lot of patients from this slum cluster every day. A lot of these patients are asymptomatic patients, and we send them home for home-based care. But in a setup like this, do you think home-based care would be able to contain the spread of disease? So every case has to be individualized, and there are unique factors which are available in our country, which are prevalent in our country, which would make home care a slightly tricky situation. Another thing that I would want to reiterate again and again, always follow the state guidelines. So as far as Uttar Pradesh is concerned, we had these, state guidelines issued on 20th July. And every patient whom we refer for home care in our hospital, we are giving them a copy of the state guidelines as to why we are sending them home. And we need to make sure that whatever rules have been stated in the state guidelines, we follow these rules to the T, so that we don't land up into medical legal trouble with the patients of COVID-19. So as far as government of Uttar Pradesh is concerned, we are supposed to give home quarantine only for asymptomatic patients. Again, this has not been very well defined, because a lot of patients would keep on having mild to moderate fever. Patients might have mild dyspnea, cough. So whether you would consider them as asymptomatic or symptomatic, well, the guidelines are not very clear. As far as UP is concerned, home care is not to be given to asymptomatic who have any immunosuppression. So any diabetic who is coming to us, even with mild disease, as per state government laws of UP, we are supposed to admit them. The patients who are being sent home should have a 24/7 caregiver. There have to be at least 2 washrooms in the house. The attendant who takes care of the patient when we are sending them home, they have to sign a form wherein they take full responsibility for being in touch with a government official or a healthcare worker. They have to regularly update the Arogya Setu app on their smartphones if they have one. And a kit is being made, provided to them by the government of UP, which includes a couple of masks, gloves, a pulse oximeter, and a ready sanitizer. Every patient who goes home for home care, an undertaking has to be signed by the caretaker that all these criteria have been met, and only then a patient has been sent home. This is for the state of Uttar Pradesh. This is something that we are supposed to follow in this state. And if the patient is unable to sign this form, the patient says that I do not have adequate isolation facilities and infection prevention and control measures at my home, then obviously the patient has to be sent to a designated area where the patient can be handled, whether it is a community facility in the form of repurposed hotels, stadium, gymnasia, or a healthcare facility if that is available. So any patient who is being sent at home, obviously, all of them should monitor themselves with a pulse oximeter. WHO says if the patient has a saturation less than 94%, they should report to the nearest healthcare facility. Temperature charting should be done for all patients. What about baseline blood tests? Well, the government guidelines in our state or the WHO guidelines are not very clear. They do not mention if blood tests are to be done for every patient at the outset. However, it is good practice to get at least the routine CBC, kidney and liver function tests, CRP and D dimers, and a baseline chest X-ray to be done for all. I get it done in my practice, but the government guidelines are not very clear about it. Every patient who is being sent home should be trained for signs of distress. The patient has to be told if you develop distress, respiratory distress, if your fever is very high, you're not feeling well, your saturation is going down, please come back to us. Every patient who's being sent home, tell them about good nutrition to be taken, hydration has to be told, and of course treatment has to be given to these patients, and that would be taken more in details by Professor Khilani. And then you need to take care of the caregivers. Patients who are at the home of the patient who is COVID positive, we need to save those people as well. So if there is any vulnerable person in the house, you need to separate them immediately. A patient who's COVID positive and has been sent home, you need to limit their movement inside the house and in shared spaces. We have to make sure that the shared spaces such as kitchens and bathrooms are very well ventilated. And other people, there has to be someone who's in charge of the patient. Other household members should avoid entering the room of the patient. And if that is not possible, they should at least maintain whatever distance they can from the patient. The recommended is at least 1 meter, but the farther they are, the better it is. And ideally, one person should be assigned to take care of these patients, a person who is in good health and has no underlying chronic disease. And obviously, there should be no visitors allowed in the houses of these patients. Patients who are taking care of these patients, caregivers who are taking care of these people, we have to sit down, talk to them, to tell them about the hand movements, the hand hygiene. We have to teach them how to wash their hands to a slow count of 20. We have to tell them, these are very basic points, but we often forget telling them to the patients who are going to take care of the COVID patients at home, that they need to wash their hands very frequently, every time the hands look dirty, every time after using the washroom, every time before eating food. And if the hands are visibly soiled, obviously the hands need to be washed with soap and water. Otherwise, an alcohol-based sanitizer can be used to clean hands. Very common question which patients ask us: can I breastfeed if I am COVID positive and I have been isolated at home with my child? Yes, a mother can continue to breastfeed. The benefits of breastfeeding are far more than the transmission of virus illness to the child. However, whenever the mother is feeding the child, she should wear a medical mask and she should perform hand hygiene before and after having close contact with the baby. Another very pertinent question that our patients ask us, and the patients, the caregivers of the patient ask us, what kind of a mask to wear, when to wear the mask. Dr. Christopher has already shown us that wearing masks is the way ahead, without which we cannot contain the spread of this pandemic. So a medical mask should be provided to the patient and to the caregiver of the patient. The mask should be changed daily, ideally, or whenever it is wet or dirty. And if the patient is coughing into a handkerchief or a cloth or in their bent elbow, whatever tissue has been used, it should be disposed of immediately, followed by hand hygiene. And every time you talk to these patients, please emphasize again and again on proper hand hygiene. This is something that I have ready in my OPD, and every patient of COVID who's going home, we are giving them these kind of cutouts where we tell them that your non-fabric woven masks and sponge masks are useless. Please do not wear these masks. If you can get hold of an N95 mask or a surgical mask, please use these masks if you are taking care of a patient with COVID-19. Many patients ask us whether they can use cloth-based masks. Well, if it's a thick cloth-based mask, and if you use 2 layers of it, then yes, it is an effective mask. However, there are a lot of flimsy cotton material masks, which are available in the market. We need to reiterate our patients again and again that these masks are not going to be effective in preventing the spread of COVID-19. So caregivers should wear a medical mask all the time whenever they are in contact with the patients. They should not be touching or handling their masks. We have to teach the caregivers how to remove their masks properly, how to discard them properly, and we have to tell them that they need to be away from the patient's body fluids, including all the oral and respiratory secretions. Gloves, again, more of a nuisance, I believe, than protective strategy. Patients coming to us in the OPD wearing the same set of gloves for the past 10 days, touching every surface, putting the gloves on dryers, and then wearing them again. We have to tell our patients and those who are taking care of these patients that these medical masks should not be reused. And whenever they are taking care of a patient who is COVID-19 positive, whenever they are handling the secretions of the patient, whenever they are touching the clothes which are dirty, linen or utensils which are dirty, they need to take care. They need to wear these gloves, but these gloves have to be discarded properly, and they cannot keep reusing these gloves again and again. Any patient, any surface which comes in contact of the patient, the attendants need to be told that we need to clean and disinfect these surfaces. We need to clean and disinfect the bathroom and the toilet surfaces at least once daily, the bathroom which is being used by a COVID patient in the household. For cleaning these surfaces of bathroom, of the room where the COVID patient is staying, regular soap or detergent can be used, but after this, disinfection has to be done by a solution which contains at least 0.1% sodium hypochlorite. And in the state of Uttar Pradesh, any patient who is being sent home for home quarantine, a government kit is being provided to the patient wherein hypochlorite solution is made available, which can be used to wash the surfaces where the patient has been, exposed. Another very important question: how do I take care of the clothes, linen, and utensils of a patient who has COVID-19 and I'm taking care of this patient? We need to tell them that this is a soap-sensitive virus. So you use a dedicated linen and utensils for these patients. But every time that the utensils and these substances have been used for these patients, they should be cleaned with soap and water. They might be reused instead of being discarded. Whatever dirty linen has been generated with a patient of COVID, put them in a laundry bag. All the patient's clothes, bed linen, bath and hand towels can be cleaned with a regular laundry soap. But if you can, use hot water up to 60 to 90 degrees centigrade, this would be more effective than killing the COVID virus. Another very pertinent question: how do I dispose of the waste that has been generated? Dirty linen, dirty tissue papers, how do I throw them? We need to tell them, put whatever waste has been generated in a strong plastic bag, clean it, close it completely, dispose it off to the municipal waste services, because the patient's address would be, updated in the Arogya Setu app. And at least in the state of Uttar Pradesh, a lot of these patients who have turned out to be COVID positive and are being handled at home, there are special, vans which are going to the houses of these patients, collecting the waste that has been generated. If such a service does not exist, waste may be buried. Obviously, you should not be sharing toothbrushes, cigarettes, cutlery, crockery, towels of patients who are COVID exposed. Another very important question that every patient's attendance asks us is, can I take any drug as prophylaxis? Doctor, I'm taking care of my father who is COVID positive. Should I take any drug? So the first drug and probably the most controversial drug in the COVID era was HCQS, hydroxychloroquine. ICMR very early put up this guideline of using HCQS as prophylaxis for SARS infection. Again, a very, very controversial topic. We still do not have the appropriate answer whether HCQS or hydroxychloroquine has any role in prophylaxis or treatment. However, the ICMR website says that any asymptomatic household contact of a laboratory confirmed case can be given 400 milligrams of hydroxychloroquine on day 1, followed by 400 milligrams once weekly for the next 3 weeks, to be taken with meals, and obviously after ruling out any cardiac comorbidity on after doing an ECG. However, what I have seen practically, a lot of our colleagues are now moving away from HCQS, and the data regarding HCQS prophylaxis is again very, very sketchy. And ICMR guidelines themselves say that it is reiterated that intake of hydroxychloroquine should not instill a sense of false security. Every patient, if you are sending them home these contacts on HCQS, we need to tell them that this drug is not panacea, and if you take this drug, it is not 100% that you are not going to get the disease. So that is something that needs to be told to the patients whenever you are giving them any kind of drug prophylaxis. Ivermectin, again, the drug in question that everyone is talking about as a prophylactic agent for COVID-19. And this is a white paper which came in the Indian Journal of Tuberculosis very, very recently. A white paper is not exactly a scientific paper. It is a very persuasive essay. An essay which looks at all the data regarding this topic, all the studies that are being done globally. And there are certain studies, especially from Peru, from Colombia, and a lot of South American countries, where they have shown in vitro and in vivo suppression of virus replication in patients, who have been exposed to COVID-19. So this white paper came in the Indian Journal of Tuberculosis, where they have tried to collect all the international data that is there on ivermectin as of now. They were of the opinion that yes, it can be used as a potential therapy for COVID-19 and also as a prophylactic therapy for COVID-19. The government of Uttar Pradesh probably was very, very impressed by this white paper. And as per a government order now, in the state of Uttar Pradesh, every healthcare professional, every patient every person who has come in contact with patients of COVID-19 and any person who is taking care of patients of COVID-19 at home has to be given ivermectin. And this is the state's rule in our state as of now. So the prophylactic dose for all healthcare workers and for people who have come in contact with COVID-19 patients and who are taking care of COVID-19 patients, approximately 12 milligrams tablet of ivermectin, which is easily available on day 1 and day 7. This is to be taken for patients who are taking care, for family members who are taking care of COVID-19 patients, 2 hours post dinner, single tablet on day 1 and day 7. These are government of Uttar Pradesh guidelines. And on day 1, day 7 and day 30 for healthcare professionals, followed by a single tablet every month. The lung deposition of ivermectin is said to be very high, and that is probably why the drug dosages have been so spaced out. And it has also been recommended for treatment. So the data as of now for ivermectin is not very convincing, but then again, it is not too bad. And because the drug is a very benign drug, there are not too many side effects of the drug. So it seems to be a safe alternative. It can be tried for prophylaxis. It is a rule for us to be used, for us to use this drug in our state. So we are using it quite extensively for prophylaxis in patients and also in healthcare workers. Patients would again keep asking you about add-on medicines, Ayush medicines, food fads, which have come into fashion being, with COVID. What we need to tell them is that if you are at home, eat a well-balanced diet, a good nutritious diet. If you are eating any Ayush medicines, patient would keep asking you whether they can take Giloy, they can take the Kada. What we tell them is you can continue, but you continue with caution, because, I'm not the correct person to tell you about whether these drugs can be taken. However, most of these drugs seem to be very innocuous, so patients keep taking them. Gastritis is a very common condition with all the drugs that we give at home for the treatment of COVID, and also with the Kadas that the patients are taking in North India. So you need to take care of that. And of course, respiratory diseases have their own unique set of food fads. People have been drinking hot water for the past 6 months in the hope that they would not get COVID-19 infection. Almost everyone in North India has stopped eating curd and rice, so that, because it is commonly associated, people think that this gives them respiratory illnesses. So all these myths need to be broken, and you need to tell the patient to eat a well-balanced nutritional diet to keep themselves hydrated once they are for home care. Last question, till when to continue home isolation? Again, this answer is not fixed. What I'm showing here is WHO guidelines. Again, for every state, the answer is different. WHO says for asymptomatic people, you need to continue home isolation for 10 days after testing positive. For patients who were symptomatic, it has to be minimum of 10 days after symptom onset, plus at least 3 additional days without symptoms. Now, this is as per WHO. Every state has their own set of guidelines. Thankfully, government of Uttar Pradesh is following the same guidelines, and for asymptomatic patients, we are asking them to continue home isolation for at least 10 days. So to summarize, there are a lot of practical considerations which need to be taken care of when you are providing home care to a patient of COVID-19 in India. Rules and laws are often not followed in India. Often it is not possible to follow them in India because of the kind of houses that we have in our country. There are no uniform guidelines for the country. The guidelines vary from state to state. The guidelines often are not very clear. So you need to individualize therapy for every person. In India, the house structures are not very ideal for home isolation. You cannot expect every Indian to have a caretaker 24/7, to have 2 bathrooms in their house, to have universal access to healthcare. So you need to isolate, you need to individualize every patient and see whether this patient would be a successful candidate for home care. Follow-up and monitoring might not be up to the mark for all our patients. Not all our patients have smartphones, and a lot of them do not know how to use them. And whatever, whenever you are sending a patient home for home care, continuous strict monitoring, being in touch with the patients is the key to successful home isolation. Otherwise we would land up into trouble. So thank you very much for your patient hearing, and over to the team. Thank you.
Enlightening and very precise
Thank you very much,
information on
Arjun.
home isolation. Yes, sir.
Thank you very much, Arjun, for very aptly describing the scenario that is required at home to even contemplate home isolation and how to do it effectively. Now we have Dr. G.C. Killani, who is set to do the last talk of the evening, after which we will have discussion. So please send in your pertinent questions on the lectures as much as possible on the, through the chat, chat option, I think. We will try to take them after the next lecture. Over to you, Dr. Killani.
So, good evening, ladies and gentlemen. My privilege to be on this program, which is crafted by Dr. DJ Christopher, and I'm really thankful to him and the sponsors for just giving me this opportunity. Now, medical management of mild to moderate COVID-19 infection is a huge topic. Unlike the previous speakers who made things very simple and clear, actually, I might actually confuse you at the end of the day. But I'll try to sort out, try to clarify things which I have learned in last 4-5 months by looking after these patients, going through the guidelines, going through the literature, which has been coming almost every day. So I have tried to make it a case-based discussion. So I start with the 40 years old male with no comorbidities who came with high-grade fever for 4 days, cough for 3 days, sore throat. The examination, he was febrile with the tachycardia, normal blood pressure. The respiratory rate was normal. SpO2 was 96 and chest examination was normal. His TLC was normal with normal lymphocyte count, and his throat and nasopharyngeal swab for RT-PCR was positive. So he comes in COVID-19 infection with the mild disease. Now, so what are the modalities of treatment for this? And Arjun has very nicely told you about the home care. My job will be telling you about the drug therapy and not go into the hand hygiene and isolation. He has so expertly has told you. So what is our armamentarium for this? Hydroxychloroquine, ivermectin, azithromycin, doxycycline. These are immunomodulator drugs. Some of them are antibiotics. Some of them have been shown to reduce the virus replication, reduce the viral load. What is equally important is the antiviral drug. We know that today the patient with retroviral disease, HIV, can have a normal life because of the antiviral drugs. So we have been talking about favipiravir, lopinavir, ritonavir, remdesivir. Some other drugs have also been tried, and I'll be discussing that part. Then corticosteroids, which are actually remain to be sheet anchor for moderate and severe disease. They are double-edged sword, and home monitoring I'll not be touching, which has been covered so well. So first talking about hydroxychloroquine, most controversial drug, politically, very important, but it has actually significant in vitro activity. It is perhaps by blocking endosomal transport against SARS-CoV-2 virus. In a small non-randomized study from France in 20% with COVID-19, hydroxychloroquine reduced SARS coronavirus 2. This effect was enhanced by azithromycin that gives a rationale for combining in this two. And in vivo study, in the observation study from New York, HCQ did not lower the risk of intubation. So it is recommended for mild and moderate disease and for prophylaxis, as uh, Arjun has told you. So what are the indications? This is indicated for pre-exposure prophylaxis for healthcare workers. Post-exposure and treatment, I need not go into the dose, 400 milligram BD for first day and then 400 daily. We all know about it. The question is, what is the evidence of benefit? In clinical trials, very little evidence of benefit. So one should not think that he has given chloroquine or hydroxychloroquine to your patient, then you have done a great thing. Nevertheless, it is part of the guidelines. Coming to the azithromycin, it is an immunomodulator drug found to be effective in decreasing the inflammation in the lungs of COVID infection. Because SARS coronavirus infections are known to induce inflammation and subsequent tissue damage in the lungs in moderate to severe cases, using immunomodulating drugs could provide a benefit in the treatment of COVID-19. Azithromycin exhibited a synergistic antiviral effect against SARS coronavirus when two were combined with HCQ, both in vitro and also in clinical setting. So sufficient evidence to add azithromycin in the treatment of mild diseases. But there is a conflicting evidence. Although it decreases inflammation, it has antibacterial activity. In one study, the viral load reduction was enhanced by addition of azithromycin. In another study, HCQ with azithromycin in COVID patient led to persistence of SARS coronavirus in the nasopharyngeal swab in 8 out of 10 patients. So again, as I promised to you that I'll confuse you, but if you ask me what do I do, if I have a mild person with a mild disease, I do give 5 days of hydroxychloroquine and also azithromycin for a period of 5 days. Coming to the doxycycline. The proposed benefit of doxycycline is that there is a clinical improvement, even reversal of cytokine storm in some infections caused by RNA viruses. It reduces the IL-6 and TNF-alpha, has shown to be having in vitro antiviral activity also. In combination with ivermectin, doxycycline has been used in trial settings and has been found to be superior to hydroxychloroquine and azithromycin combination. Those, of course, 100 milligrams twice a day for 5 days. Arjun talked about ivermectin. leads to in vitro reduction of viral RNA in Vero H SLAM cells 2 hours post-infection with SARS coronavirus 2 clinical isolate. And however, the flip side is the SARS coronavirus 2 inhibitory concentration for ivermectin are not likely to be attainable with the dose of 12 milligrams that we are giving. However, a retrospective cohort study showed significantly lower mortality rates with ivermectin. So majority of them are uncontrolled trial. So if you ask me how do I use this information which I give, as we know that hydroxychloroquine, one has to be careful in patients who have got QT prolongation. There is a risk of arrhythmias. Similarly, azithromycin also leads to QT prolongation, and we have seen it all. So therefore, if the patient does not have hypertension, CAD, risk of arrhythmias, the ECG is normal, QT is normal, then I give them a combination of hydroxychloroquine and azithromycin. However, if I have slightest risk of arrhythmias in these patients because of their comorbidities, I use ivermectin and doxycycline combination. Now, this is my absolute personal choice. You can take it as you like. Coming to the antiviral, a drug which for sure would reduce the viral load. And ever since the COVID-19 came as a pandemic, the medical fraternity has been trying to find and testing drugs which have been previously used for RNA viruses and other viral diseases. So favipiravir is selectively inhibits RNA polymerase, which is necessary for viral replication. It's an oral antiviral approved for treatment of influenza in Japan and has been used for Ebola. In fact, its use has been taken from the experience from the Ebola virus. So, what is the evidence of benefit? In the mild disease, that is with the SpO2 of 93%, this is a study which is published. This is from China. There is a faster rate of viral clearance, that is median time to clearance was 4 versus 11 days. Quite seems to be very impressive. And radiological clearance was 91 versus 62% compared with lopinavir and ritonavir. So there is a uncontrolled trial, and also there was head-to-head trial with lopinavir and ritonavir. The limitation is that these were non-randomized trials. Another study where it was compared with umifenavir, large number of patients, I would say 116 versus 120 for moderate diseases. What it showed that favipiravir had faster recovery and there was reduced incidence of fever and cough. The third trial was a randomized trial for mild to moderate disease, which is only in the form of abstract. And there was 62.5% clear of SARS coronavirus 2 virus within 4 days, and it was found to be safe and well tolerated. This study the abstract came on 9th August 2020. So in the United States, a phase 2 trial will enroll approximately 50 patients in collaboration with Brigham to study the efficacy of favipiravir. Meanwhile, the DGCI, Drug Control General of India, has approved favipiravir for treatment of COVID-19 infection with the rider for the mild to moderate infection. The dosages are 1800 milligram twice daily on the day one, and then so one has to take 9 tablets twice a day on the first day, and then 4 tablets twice a day subsequently. Lopinavir ritonavir, from the experience of retroviral, was initially tried as a desperate measure, and in fact there was a study in the New England Journal of Medicine, but in the randomized trial there was no benefit of lopinavir and ritonavir, and this had almost been given up. So the above case scenario now after being home quarantined and on asymptomatic support, 42 years old male, he continued to had high-grade fever persisting for 10 days. Cough was persisting for 10 days. He had breathing difficulty now. So on examination, he had fever of 102. He had tachycardia. The BP was on the lower as compared to the initially. If you recollect, the respiratory rate was 30 per minute. The SpO2 was 88% on room air. Chest examination was normal, and rest of the systemic examination was normal. The arterial blood gas analysis showed the PaO2 of 56. So this patient had hypoxemia, he had breathlessness. Now this patient is now admitted to the COVID ward and started on oxygen support of 6 to 7 liters per minute. An investigation showed that CRP was 97 with a normal of 5, D-dimer was 1800, ferritin was 778, LDH was 540. He was now started on steroids, anticoagulation, and with oxygen support. CT chest of this patient was done, which showed the following picture. And as you see, and I'm sure all of you have seen several of them peripherally placed ground glass opacities, and I am not here to tell you variety of radiology that we see because that's not a thing that we are discussing. So any clinician, any radiologist will say even if the RT-PCR is negative, with this kind of CT, they said this is COVID-19 infection today, even if the RT-PCR negative. And actually, this is the practice. And one of the studies showed the sensitivity of CT scan was much higher than the sensitivity of RT-PCR for diagnosis of COVID-19 infection. So this has now progressed to moderate severity COVID-19 infection. So what are the additional treatment drugs available for these type of cases? And this is what I would be discussing with you. Corticosteroids. The corticosteroids have a good inhibitory effect on inflammatory factors and are often used as auxiliary treatment for viral pneumonia. But if you recollect the H1N1 and the other viral outbreaks, corticosteroids were counterproductive. It was discerned that corticosteroids increase the mortality. So therefore, at the beginning, we were very wary of using corticosteroids in moderate and severe cases. The main anti-inflammatory effect of corticosteroids is to inhibit a large number of pro-inflammatory genes that encode cytokines, chemokines, and inflammatory enzymes. What changed the game was the recovery trial, which came in May, and they said that 10,000 UK people could have been saved if the steroids were used early. The results of this recovery trial, it was announced on 16 June. They showed a strong benefit for dexamethasone over a placebo in this trial with 6,425 patients. In the another COVID-19 dexamethasone randomized clinical trial, investigators found that addition of dexamethasone to usual care versus usual care alone significantly improved the number of days alive and days patients were free of mechanical ventilation over 20 days. So amazing results with this, and this is important thing which came in JAMA very recently. It included 7 randomized trials with 17,003 patients and patients in over 12 countries. This meta-analysis found that administration of systemic corticosteroids compared with usual care or placebo was associated with lower 20 days all-cause mortality. So no questions about it. If the patient is requiring oxygen, if the biomarkers are high, or if I'll come to it later in the discussion. The next question comes, which salt of corticosteroid is the best and what dosages and what duration? The recovery trial used dexamethasone 6 mg, which is equivalent to 160 mg of hydrocortisone and 32 mg of methylprednisolone and 40 mg of prednisolone. What I want to emphasize is that it's not more the merrier. I do see people using 120 milligram of methylprednisolone intravenously. The dose some people like to use is 1 to 2 milligram per kilogram body weight. But my thinking is that we should restrict it to the what recovery trial had said. So we should not use more than 1 milligram per kilogram of methylprednisolone, or for instance 200 milligram of hydrocortisone. The meta-analysis suggested that dexamethasone has the best odds of uh, saving the lives, after that hydrocortisone, and third was methylprednisolone. But you can make your choice depending upon the local condition. Another question is, should be the duration of steroids? 10 days is the usual thing. Now the question is that once the patient is discharged, should we give them steroids? Now that's a very difficult question. There are no guidelines for this. But however, if at the time of discharge, if you are suspecting that this patient may go into the pulmonary fibrosis, and how do you do that? If the lung shadows are dense, they are in the form of consolidation. If they are associated with interstitial thickening, if they are associated with organizing pneumonia, if there is the slightest pleural effusion, or if it is associated with mediastinal adenopathy, these are the subjects who are likely to go in pulmonary fibrosis. Or if the biomarkers are high at the time of discharge, then you use corticosteroid for 2 to 3 weeks. This is also arbitrary, not based on any kind of randomized trial. So 2 to 3 weeks of tapering doses of post-discharge can be used and should be used in patients as I have described. What about anticoagulation? We have understood the part of pathology from the autopsy studies, from the D-dimer test, that COVID-19 infection is a prothrombotic state with a risk of thromboembolic complication. The pathophysiology of ARDS, as seen in autopsy studies, is different from the usual ARDS. There is angiogenesis, there is thrombotic state. So anticoagulation, it improves the outcome, including survival, as uh, published in the American Journal of Cardiology. Low molecular weight heparin is the drug of choice, out of which my choice is enoxaparin, and I use in single dose of 40 milligram subcutaneously daily. At discharge, newer anticoagulants can be considered like apixaban or rivaroxaban in patients who have raised biomarkers, especially D-dimers, for a period of 2 to 3 weeks to be monitored with the D-dimers. Therefore, the International Society on Thrombosis and Hemostasis issued an interim guidance recommending measurement of D-dimer, fibrinogen, prothrombin time, and platelet count in all COVID patients. So, therefore, after the steroids, the anticoagulation is one that we have got evidence that it improves the outcome in this patient. For the treatment of COVID-19 patients associated hypercoagulability, the administration of anticoagulant has been reported potentially improve prognosis by studies. So now I'm coming to the last part as to antiviral therapy. We have two drugs which can be used for remdesivir and favipiravir. I've already described the favipiravir in great detail. Now I'll be discussing a drug called remdesivir. Remdesivir is a nucleotide prodrug whose active metabolite inhibits viral RNA-dependent RNA polymerase that play a key role in the replication of broad range of viruses, including coronavirus. Initially, it was preferred to use in severe cases due to limited studies. There were 3 studies which were done. 2 were negative, 1 was positive. The positive study convincingly showed that it reduces the duration of illness but does not improve the mortality. Although the mortality was 11% and 7% in the favor of remdesivir, but it did not reach statistical significance. So FDA in emergency authorization on 1st May 2020, it said that it can be treatment for suspected or lab confirmed COVID-19. Adults and children hospitalized with severe disease with saturation of less than 94% require supplemental oxygen, require mechanical ventilation, or on ECMO. Remdesivir is the drug of choice. Now, it is to be given for 5 days, because when it was compared, the 5 days remdesivir treatment was as good as 10 days. So 10 days therapy has been given. And this particular study I was referring to, the median time to recovery was 11 days versus 15 days, and this was statistically significant. And this was the one which led to the FDA, which gave an emergency approval for use of remdesivir for severe patients. So it was, we were using remdesivir for patients who were critically ill, who were requiring uh, high flow oxygen, who were on NIV, and who had high chances of receiving mechanical ventilation. Till the time this study came, only 3 days back, this was effect of remdesivir versus standard care on clinical status at 11 days in patients with moderate COVID-19 infection. This was a large multicentric randomized trial comparing 5 days and 10 days of remdesivir therapy, and this was conducted in 110 centers across the globe, that is United States, Europe, and Asia. As I already said, the remdesivir is a nucleotide produced prodrug whose active metabolite inhibits viral RNA dependent RNA polymerase that play a key role in the replication of broad range of viruses, including coronavirus. As I said, this study with nearly 600 patients in 105 hospitals across United States, Europe, and Asia. These patients had radiological evidence of pneumonia without hypoxemia. That, please note that. And this is a game changer. These patients did not have hypoxemia. The result was assessed on a 7-point ordinal scale was used. On day 11, patients were randomized to 5-day remdesivir group at significantly higher odds of better clinical status distribution on 7-point ordinal scale compared to with those randomized to standard care. That P is equal to 0.02. There were increased rate of discharge on day 6 in 5-day remdesivir group. The difference in the clinical state distribution on day 11 between the 10-day remdesivir group and 5 days standard care group was not significant. So whether you give it for 5 days or 10 days, it doesn't matter. The adverse effects were nausea, hypokalemia, and headache. I must tell you that you must look at the creatinine clearance. This study took less than 50 as a cutoff. The previous study had taken less than 30 as cutoff for giving. The conclusion was that remdesivir treatment for 5 days had significantly higher odds of having a better clinical status distribution on day 11 than those receiving standard. I must tell you that the mortality was not significantly different. The reason is that the overall mortality was 1 to 2% only. So it was not possible to discern difference in mortality because of the low level of mortality. A word about oxygen therapy. I'll just flip through it. The nasal cannula, simple oxygen masks. You all know about it. Depending on the what is important is high flow nasal cannula. High flow nasal cannula came almost a decade back. It was used in hypoxemic respiratory failure, but it has found a special place in management of COVID because it has been found in clinical studies to be extremely useful. What we do is that this is aerosol generating. We try to use as little flow as low as possible, generally not to try above 40 liters per minute. Over and above the high flow nasal cannula, we use a simple mask to avoid the aerosol generation. The advantage is that it is possible to prone the patient while the patient is on NIV. Some people are also using NIV and high flow nasal cannula alternately, because the NIV high flow nasal cannula is more patient friendly. Patient can speak, patient can drink, patient can eat, so he doesn't have to remove that. When you give BiPAP, there are a lot of issues of uh, air leaks, fitting of the mask, and all those things. So, and the patient may become claustrophobic. So, therefore, you can actually alternate between BiPAP and high flow nasal cannula in sickest of the patient, and people have found it to be useful. So, and of course, we all know about the awake proning, which has actually come for the first time in the history of critical care. The proposed physiological benefit of prone position patient is reduced pressure on the lungs, beneficial in fluid shift, improved VQ match, and improved secretion clearance. Although, to my mind, there is no evidence that it improves the survival, but the oxygenation certainly improves. So I'll not go into the criteria in the interest of time. I think a word about convalescent plasma. It has been in a vogue, and there are several trials which have been published. The Mayo Clinic published 20,000 cases and only published the safety of convalescent plasma. Most of the randomized trials have not shown clear-cut survival benefit in patients with plasma, but it's very easy to administer. My thought process would be that if you have to give plasma, don't wait till the time the patient is on ventilator. Give it early in patients with moderate COVID infection when the oxygen requirement is there, and selection of the donor should be done very carefully. And of course, variety of CT scan be there. This is a more sinister looking CT with the peripheral dense. These are the patients who are likely to go into the pulmonary fibrosis, which is not a point of discussion. So when do we discharge the patient? The patient can be discharged after 10 days of symptom onset and no fever for 3 days. There will be no need for testing prior to discharge. This is in the mild cases. At the time of discharge, the patient will be advised to isolate himself at home and self-monitor their health for further 7 days. In the moderate cases, patients whose symptoms resolve within 3 days and maintain saturation above 95% for the next 4 days. Cases clinically classified as moderate cases will undergo regular monitoring. If the fever resolves within 3 days and patient saturation is above 95% for the next 4 days without oxygen support, such patient will be discharged after 10 days of. The key is that you have to count 10 days from the beginning of the symptom, and you must uh, ensure that there is no fever without antipyretics, resolution of breathless, and no oxygen requirement in majority of cases. Uh, Patient on oxygen whose fever does not uh, resolve within 3 days on demand on oxygen therapy continues, such patient will be discharged only after resolution of clinical symptoms and ability to maintain oxygen saturation for 3 consecutive days. This is a generalization, but there would be patients who develop pulmonary fibrosis and continue to be on oxygen, and ultimately you have to test them COVID negative and send them on sometime on oxygen, sometime on even on BiPAP for that matter. So I'll not talk about retesting by RT-PCR and in the interest of time. So I would summarize this. Uh, I end my talk by summarizing that what should be done if the patient comes for evaluation in the hospital. You have to do COVID test. Recommendation: self-isolation, proper hygiene, regular washing, and treatment I've already described. Either you give HCQ azithromycin or doxycycline and ivermectin. Favipiravir is to be given for 14 days to reduce the viral load. What should be monitored? The patient should be monitored for oxygen saturation. Now, for the treatment of the moderate cases, which is actually a large group, what should be done if the patient comes to evaluation or hospital? With SARI, do the COVID test, patient should be admitted, and then the treatment should be HCQ, azithromycin. It's the same. Steroids and anticoagulation should be decided on case-to-case basis. In the outpatient setting, favipiravir can be given. In inpatient setting, remdesivir should be considered. I've already described the indication for giving remdesivir and convalescent plasma. I also want to tell you, please don't use steroids left, right, and center. If the patient is maintaining oxygenation, if there is a bilateral pneumonia, and if the uh, markers are not very high, if the CRP is less than 10, please refrain from using steroid, because the Albert Einstein Institute study has clearly shown that when the CRP was less than 10, the mortality using steroids were high. So, what should be monitored? Regular monitoring of vitals, and of course, I've already told you, and use of remdesivir and plasma. So, ladies and gentlemen, I thank you very much for your patient hearing. I have tried to cover as much as I could, and I'll be happy to take question. And I once again thank Dr. Christopher and the sponsors for giving me this opportunity. Thank you.
Thank you, Dr. Kilnani, for that very exhaustive and very in-depth assessment covering virtually the whole spectrum of treatments available. Thank you very much. I want to start where you stopped. You said do not give steroids unnecessarily. I want to
Yes.
start there and reiterate that, in mild disease, the thinking is that earlier you give, even better. If it works in severe, it should work in mild. But that doesn't work in medical science. So in fact, the people with mild disease where steroids is not indicated, the mortality is higher. So we should be cautious about placing our treatments in the right spot. I want to start. We have a lot of questions on treatment. Therefore, before that, I want to start just move away from pharmacology a little bit and come back to it as we sign off. So one question is this a man-made pandemic? Well, I wish I knew the answer. Although there is a lot of discussions about it, lots of views have been expressed against it, especially in the early days, and lately more towards it. So I think this debate will rage. I hope finally somebody would prove it one way or the other. But as we speak, we do not know. But there is potential for man-made pathogens to cause havoc in man. That is undisputably true. So such pathogens being used for biologic warfare is very, very plausible. And I hope countries don't use this as a weapon. Dr. Kilnani, you wanted to say something?
No, one part you have already answered, but I have a thinking. We are disturbing the milieu of animal kingdom, and this has been said by the WHO also. And we are encroaching the jungles. We are encroaching the. So there's no question that this came from Wuhan, from a place where live animals are being traded. So one of the thought process is that it is man-made in the sense because we have, that includes global warming and disturbing the animal kingdom and encroaching the. So that part I wanted to bring up. So, but I don't know
Yes.
much about it.
Yeah. So I think there are arguments for this and that. The fact is nobody knows the truth.
No, that's right.
Yeah. And someday I hope, if it is man-made, I hope it is known so that mankind can prevent such things from happening in the future. The next question is, how long will it take for herd immunity to set in? Just before the session, I was discussing with Dr. Arjun, and we both felt that this is here for the long haul. We were just, Delhi is just reporting the second spike. We thought after the huge spike and such a bad run it had that while we knew it is not going to disappear, we didn't expect another spike of this magnitude. So this virus is really behaving unpredictably. So we haven't seen the end of this virus. My belief is that there will be multiple spikes in multiple different places of the country, because each place is in a different timeline and will probably have a different peak. And it is likely that the pandemic will move from the tier 1 cities to tier 2 cities, such as Vellore. In Vellore, we are beginning to see a huge spike. And so this is likely to happen. And then it is likely to go to the rural parts of the country. And I believe, very unfortunately, that many will quietly die and it may not make headlines. But a lot of life will be lost because medical care is not so good in the rural areas. So we will hopefully wait that maybe a vaccine may come up, or before herd immunity. Herd immunity is a very costly option. A lot of people need to be infected to get there. So my hope is that vaccine will come before that. The next question is there risk of sudden cardiac death? Well, one of the features of this virus is involvement of the myocardium, and also people with cardiac comorbidities have a higher chance of death. In fact, it is little more than those with respiratory comorbidities. So definitely the virus does something, and there are now studies that have shown activity, even much like we talk about sequelae in the lungs post-COVID. Cardiologists are detecting in studies that there is sequelae in the heart also post-COVID. So cardiac death, certainly, sudden death is certainly, we know patients deteriorate rapidly and die, and we do not know to what degree cardiac factors are involved. So it is quite likely. Dr. Kilnani and Arjun, have you anything
Yeah,
to say?
so I know little about it. The autopsy studies have been conducted. There is a myopathy. The cardiologists have seen clots in the large vessels without seeing plaques, meaning by that these are de novo. And third thing is that there have been incidences of massive hemorrhagic pericardial effusions with COVID. And in our own experience, we saw bradycardia in many patients, and we were always scared. And some patients have high troponin levels also, we keep monitoring. So, like other organs, heart is also involved, and this being a prothrombotic state, it stands to reason also.
Yeah. Arjun, you had anything to add?
Absolutely, sir. It's the same. And the bradycardia, raised troponins, we are all seeing them. And because the COVID virus has a unique propensity to involve the vascular beds, not only the cardiac or the pulmonary vascular beds, it is said to be more of an endothelial disease. And because of this endothelial propensity, we do get to see a lot of cardiac comorbidities. And of course, sudden cardiac death has been very well reported. And now we've all seen it probably. We've all experienced patients with COVID having it.
Right. The next question is about the chance of reinfection. What is the risk of reinfection? So, do one of you want to comment on that?
So, cases have been reported. Reinfection has been reported around 2 days back. This was again from Ghaziabad, that two doctors cases were reported. These two had mild disease, and actually the virus genome was also picked up. It was also studied, and it was actually a mutant virus. So these two doctors had become negative for a month, and then after that had repeat mild symptoms, sore throat, and both of them tested positive. But the virus, the genomic structure of the virus this time was different. It was a different strain which was causing it. So it does seem to be a possible threat. We do not have the exact answer right now. There have been reports from South Korea as well, wherein repeat infections have been shown. But in my clinical practice, we've now been treated in COVID now for almost past 4 months. I am yet to see it, or probably, I do not have access to genomic studies or, such investigations. But I think it's a distinct possibility. And maybe by the end of next year, or when enough time has passed, we'll get a clear answer on that.
So one thing is that it's not very common. So
Yeah.
we do not want people to.
Let us put it, with almost 2.8 crore cases, it is exceedingly rare as of now.
Yes, yes, that's the most comforting thing. So for people who get cured, I think they should rest with a certain degree of assurance that they probably won't get it back. I think that's a good thought. So the next question is about the drug treatment for lung sequelae of COVID-19. So the
So,
one question is trypsin, chymotrypsin, pirfenidone. Dr. Kilani, you have done a session recently.
yeah, I have done this session, and this is a FAQ, frequently asked question. About 5% of the patients have residual lung disease. That's what, and in fact, the medical fraternity, pulmonologists are dreading this. That the number of cases who will be left with pulmonary fibrosis. Now, the thing is that we do give steroids to them because they are still, slightly hypoxemic. The CT is showing still lung shadows. Some show fibrosis very early. And I already narrated which are the radiological pictures which goes into fibrosis. But it is also certain that we don't know whether the corticosteroids would reduce the fibrosis. Possibly not. Now, the autopsy studies have shown that pathology of fibrosis, which is associated with COVID, is entirely different from what we see in idiopathic pulmonary fibrosis or non-specific interstitial pneumonia. There is no similarity in pathology. So, first comment is that we don't know whether the corticosteroid would prevent further fibrosis. Coming to the two drugs which have been proposed and not so tried in a organized way, that is nintedanib and pirfenidone, which we are using now for not only for idiopathic pulmonary fibrosis but also for other fibrotic lung disease, as the evidence has. The two, the nintedanib is the one which, if you see the Kaplan-Meier curve, the the curve starts separating in 4 to 6 weeks. They start separating early. So probably, as compared to the Ascent trial, the nintedanib will act faster, and also it leads to reduced exacerbation of at least in one trial with nintedanib showed. So the pulmonologists are actually hoping that uh, nintedanib will be helpful in reducing the pulmonary fibrosis. It won't cure the pulmonary fibrosis. With the rider, the nintedanib has some interaction with the oral anticoagulants, newer oral anticoagulants. If you are giving oral anticoagulant, then you should be wary of using them together. Pirfenidone is more tried in Indian setting because we started using pirfenidone much before it was approved in the Western countries. So I really cannot say which one is better, but it's only extrapolating what we learned from IPF studies that these drugs, but you have to treat the patient. So therefore, I don't want to confuse you. If you are
Yeah.
showing interstitial fibrosis in the lung 3 weeks after the patient is discharged, and the patient is the vital capacity is low on PFT, and 6-minute walk test has been found to be a very useful test for assessing the lung condition in these patients, and now we are doing it regularly. And if in your wisdom you think that pulmonary fibrosis is setting in, use either nintedanib or pirfenidone. Only time will tell whether you are wiser or not.
Right. So what we require is well-conducted studies. I hope somebody does
But there,
trials and
no, but sorry, I am interrupting you. But look at how many years it took for pirfenidone studies to come in. It took 5,
Mm.
6 years. So they are not going to come faster than 6 months at least,
Right.
because they reduce the decline in lung function. They don't improve the lung function in majority of cases. That's the thing. So
Right.
not giving a
Right.
good news, but that's what it is.
Yeah. So, I mean, we are looking at a not a very good future in that sense from the pulmonary point of view. Let us hope it is not frequent, and let's hope that these drugs or other drugs actually work in these patients. I want to quickly dive back to some antiviral questions. Uh, Arjun, I have a couple of questions for you. There are two questions very related. He says, can we use remdesivir in all RT-PCR patients? Another one has actually asked, can we even do it before we see the results? So a quick response from you. We have about 10 minutes. So
Answering on remdesivir, if you look at the way remdesivir has, the evolution of remdesivir, initially it was to be given as a compassionate drug for the sickest patients. And over a period of time, now there are reports coming from US wherein states of US have actually approved remdesivir as a primary drug to be given to all admitted patients. And we have seen in our clinical practice, there have been three distinct eras. One was the era wherein when COVID set in, there were no antivirals. Then was this month where we had more access to favipiravir. And now that we have all antivirals, both the antivirals available, remdesivir and favipiravir with us. Now, probably it is that we are getting a lot of sicker patients in this episode, the second type that Delhi is seeing, and by default we are getting to use a lot of remdesivir in our patients. So what I feel is it does tend to work. All that early data wherein it was found to be useful only in patients who had hypoxia, severe hypoxia, and it was approved only on compassionate grounds. I think we need to lose our guard a little bit. We need to come down. We need to, be a little less staunch about it and probably extend the usage of remdesivir. That said, sir, we must understand that viremia in COVID is in the early part of the disease. And you need to the same again with favipiravir. Favipiravir works best when it is given early, when the patient is actually in the stage of viremia. What's the point of giving remdesivir to a patient when the patient is already landed up in frank respiratory failure, when the patient is already fibrosis setting in, when the patient is already too sick, and when the patient is post the period of viremia? So yes, it is a very it is a very intuitive, it is a very good concept of giving remdesivir very early in the stage of the disease, wherein patient is actually in the viremic phase. And if you can suppress the viral replication at that time, maybe, God knows, maybe we would have less complications. But unfortunately, as of now, if you see most of the guidelines, remdesivir would be used in patients at least, till the time, by the time they have moderate disease. So the exact answer to that question, I would say, is still not known. But I think over a period of time, we would have better answers to that. But yes, I personally, it might be a biased opinion because I work in a tertiary care center where we get most of the patients who are already too sick, but I think it tends to work.
okay.
But
So
the
you feel
study which has come 3 days back, where the remdesivir has been given, where actually there is no hypoxemia. The inclusion criteria was that there was pneumonia and SpO2 was more than 94% on room air, and then it has shown benefit. So my take would be that if there is a pneumonia that you, and nowadays in a tertiary care center you are doing CT first. Straight away you go for a CT scan. If there is a significant pneumonia, that means the disease has is quite severe. Now there are patients who have got 60% involvement in the CT, and you don't see hypoxemia at rest. The SpO2 continues to be 95, 96. Prior to that, what we were following is biomarkers. If the CRP and the ferritin and the D-dimer, they were raised along with bit of pneumonia, we were giving remdesivir. But now I will further bring it down with this JAMA study, which is actually a well conducted trial in 105 centers.
Right.
So that's yeah.
So we already have evidence that if there's pneumonia, then you don't have to wait for hypoxia to set in. You can start treatment.
If
I
you are
think we can
waiting, then
draw
you
the
are doing
line.
a disservice.
Right. So that is the position where we are in, and we have to watch this space, and I'm sure things may change in the future. The next question is about antivirals in pregnancy. I just want to give a quick comment there. Interestingly, in pregnancy, it has been associated with milder disease. I say this confidently because we just had a presentation of 80 women in our hospital this morning in a session. In 80 women, only one required invasive ventilation. All the others pretty much recovered. So there is some evidence that that estrogen is protective, and so they seem to do well. The question is about antivirals in pregnancy. Do any of you have any? I know favipiravir has probably teratogenic effects, if I'm not mistaken from memory. Do you any thoughts?
My take would be, first that of course nobody knows the teratogenicity of remdesivir. We also know that COVID does not affect pregnancy and childbirth exceptionally adversely. So one doesn't have to be over enthusiastic about antivirals. I would say first trimester no. Second trimester think, third trimester don't worry. Give remdesivir. But that's from here, not from the literature.
Yeah, and in pregnancy, surely you will not give it early. You would probably wait for the indication.
Be conservative because
it.
we have seen that COVID does not affect pregnancy exceptionally adversely. So that's my take.
Right. So there's a question which is a little out of the way. Mefenamic acid indomethacin for cytokine storm. I mean, there are other drugs that have been used for cytokine storm, but I haven't heard of this.
No idea.
Yeah, so obviously, I mean, we can say straight away that there is absolutely no role. As of now, even tocilizumab, we are still waiting for good evidence. So that is probably one of the drugs that has been used in cytokine storm. We still don't have a... Yes, Doctor.
Yeah, since you have brought up this issue, I must air my views. Tocilizumab we have used quite a bit, but one should be extremely cautious in patients who are immunosuppressed using tocilizumab. Especially like I work in a hospital which is dedicated to kidney and liver. We have a lot of patients with CKD and post-renal transplant. I'm not using it.
Right.
And so I would like to add a point to that for tocilizumab. If it is an indicator, if the patient has an indication for the, for tocilizumab and the patient does not have a comorbidity and the patient is in the cytokine storm, young patient or otherwise healthy patient with not too many compromising comorbidities, I think it works. I somehow, I do not agree with the data, the Roche data that came up, negating effects of tocilizumab. And we are actually in the process of collecting our own data in our center. We have used it in around more than 300 patients now. And for majority of the patients, we have used only a single dose. In a few patients, we have gone as high as 3 doses. But my gut feeling is that our data is going to be positive. And provided,
Arjun, unless you conduct a randomized trial, you can't be sure about that.
Yeah,
and I've spoken to people in New York who have the very large experience. They are not very enthusiastic. Neither the data are supporting it. I don't say don't use it, but use it carefully. But don't go overboard. That's what my
absolutely, and that's the take-home message. It has to be used
and
in
other thing is that IL-6 levels are very erratic. They don't.
Absolutely.
They go with, unlike CRP, and they don't go as you expect. They are very erratic to my mind.
Yeah.
Absolutely.
And people have not used IL-6 levels to decide on tocilizumab therapy either. Whatever studies are published.
See, the thing, what what people are using when it suits them. They use IL-6 level. When their gut feeling says, okay, I must use, this patient is dying. And if the IL-6 is high, they use it. But second day you do, the IL-6 goes up. That, of course, there's a reason for that. But we'll have to wait for data to come for it to, be in the mainstream, because tocilizumab has been used quite a bit now. I've also
I
used
think
Arjun. I'm not against it. We use it regularly. I'm not against it. No.
and in fact, after when steroids have become established treatment, tocilizumab has slightly slowed down, is my feeling.
Sure.
Right? So we have evidence of something that works. Now we are adding another drug that could potentially immunosuppress. So that is the take. Okay, now we are moving on to the next area, which is the area of anticoagulation. I think we have reiterated, all of us, that this is a procoagulant situation, and patients develop DVT, pulmonary embolism, even strokes, and of course, as Dr. Kildani said, there is de novo microthrombi in the pulmonary circulation. So all this is the nature of disease. So what is your take on anticoagulation in the COVID patients?
So all the patients who have moderate disease uh, should have the benefit of anticoagulation, and low molecular heparin is the drug of choice. If you cannot give low molecular heparin for some reason, then other unfractionated can also be tried. It is also thought that newer oral anticoagulants like apixaban or rivaroxaban are also equally effective, but more experiences with, as I said in my presentation, that when the patient is discharged, they can safely be put on newer oral anticoagulant. Consensus is for 3 weeks, 2 to 3 weeks, but that will be decided on the one. If you want to ask me one parameter to decide, that is beta. Can't
So
hear you.
you've muted yourself, sir.
So, Dr. Kilnani, you are talking about prophylactic anticoagulation, right? So, are there
Not. This is all prophylactic. Yes, of course.
So,
Yeah.
are there situations where you consider therapeutic anticoagulation? What are they?
Actually, this question I have discussed with at various, whether the pulmonary embolism is more common, this being a prothrombotic state. So, my comment is that all the patients who are moderately or severely ill are getting sometimes therapeutic dosages of anticoagulation in terms of twice a day low molecular heparin. So we really don't know whether the pulmonary embolism, and we are not doing CTPs so commonly and so easily in this COVID patient. So actually, I'm not aware of whether the pulmonary thromboembolism is more common in COVID patient than in the usual critically ill patient. So I really don't know. But we are also not doing fibrinogen levels and all those things which are probably more useful. There is some people have used even fibrinolysis in certain situations, but I have not used that. So I don't know whether I have answered your question.
Yeah, I think so. So basically, in our critical care, for example, there is any unexpected deterioration, since they cannot image, then they move from prophylactic to therapeutic. So that area still there's no absolute clarity, and centers change have different practice. But a lot of patients in the critical care unit, ventilated, are on therapeutic anticoagulation.
Yes, I agree. But there have been cases of intracranial bleeds and things like that. I'm aware of that, not in my hospital.
Sure.
Maybe Arjun has some experience of that.
So we have thrombolized, as sir said, 2 or 3 odd patients wherein the levels were very high. We were obviously not able to do CTPAs for them. But then we had indirect evidence of pulmonary embolism with 2D echoes, pro-BNP being very high, and clinical evidence of pulmonary embolism was very, very high. So we actually gave it to 2 of our patients. One led to death, the other improved. So,
So if there is direct and indirect evidence of pulmonary embolism, I think we should give it.
Yeah.
The threshold should be low to give
Yeah, of
treatment,
course,
then
we have to.
direct or indirect evidence. So when I say direct, I mean by you are able to image. But in critical care, you are not able to. You don't have the luxury of imaging COVID patients in critical care. So we have to accept that, and definitely those require
Yeah.
anticoagulation, therapeutic anticoagulation, right? So I think we are heading towards a close. So the last and an important question is, what you both feel about the status of vaccine research, and when do you see it as likely to come? It's a $1,000,000 question.
Let the young person respond. Arjun, what do you think?
Sir, I wish it comes. I'm tired now. I want it to come. I guess
Yeah.
I'm frankly, I'm tired. I'm sick and tired now. I just wish it comes soon. I don't know when it is coming. I'm ready to go to Moscow to get it, but I wish it comes soon.
No, but the thing is that there are certain issues with the vaccination that we must understand. Going through the media news, and that's one part of it. And one of the top experts said that, look, hepatitis C is a RNA virus. In 20 years' time, we haven't had a effective vaccination. Well, that's a little depressing. But there are other RNA viruses where the good vaccines are there. But the thing is that there are issues about coronavirus vaccine. It will probably come in the March, April, as everybody is saying. The question is of its safety. Probably it will be safe. Efficacy, periodicity, and all those things. How frequently it will be required to be given. Whether it will prevent infection as it happened in smallpox or in polio for that matter, or whether it will reduce the severity of corona infection. All those questions, nothing is known about. We are too early in that. Uh, that's what I think. But if you are optimistic, then March next year. I would put it this way.
Now, I
And
kind of
at
agree
least,
with.
at least some, because so many, as many as 160 candidates vaccine have been tried. One thing that at least one will be effective for Arjun at least. For him to go to next time.
I
Yes,
don't. I
absolutely.
don't think vaccine research has been so heavily populated. As you said, 160 candidates are being tried in different phases. So let's hope that one of them is the Mr. Right.
Yeah,
And the
so
one
that's what
question
I
that
think.
I have is that they should not bypass the pathway of not just phase 2 but phase 3 clinical trials before they throw it out on the population. Because
But you see,
potentially,
the phase 3 clinical trial is a very big trial. It should run in thousands of patients. One. Second is that there is a difference between efficacy and effectiveness. That is, you have you have got antibodies when you feel that your lymphocytes are primed or whatever memory cells. Whether they actually prevent infection,
mm,
that part is, it's further. It takes very long time to prove that. So,
absolutely. Well, I
sorry,
really
I'm sounding depressing, but
no.
that's
You're absolutely
really.
right. You're absolutely right. So it is easy to demonstrate antibodies. Now we cannot take that as proof that it is going to be the panacea for humans, and it will prevent infection in majority of us. So therefore, that requires more rigorous and time-consuming trials.
And
So
one
that is,
study which came from Iceland, sorry, I am interrupting you.
yeah, go ahead.
From Iceland, one study came where they did very extensive antibody testing for a period of 4 months in patients, and found that in more than 91% of patients, the antibodies were persistent, the neutralizing antibodies. So
Bodies.
that was very encouraging study published. I've gone through in the greatest of the details in that.
Yeah, yeah. Yeah. There is
There's something encouraging also. It's not that everything is depressing.
absolutely. Just want to add to that encouragement that there is also study evidence showing that there is T cell
Yeah.
engagement,
Yes,
which
memory
means
sense. Yeah,
Memory
memory,
cell.
yes, which means there is hope for lasting immunity. So
yeah,
all
sure.
this to translate into reality in human clinical trials in a phase 3 level, and that is our hope,
Yeah,
right? So Arjun,
yes, sir.
anything parting before we close?
So we are right now in probably the worst peak that one could ever imagine. I was always dreading, Italy-like situation or a Iran, France-like situation, and probably at least in my hospital, we are right in the middle of that kind of a situation.
Yeah.
And I think whatever we have learned in COVID management as of now, I think the basic take-home point is hit fast, hit hard. For example, for remdesivir, thankfully now there's data that you can give it as soon as the patient has pulmonary infiltrates, the patient has any evidence of pneumonia. Same with steroids. As soon as the patient starts developing respiratory failure, right at the outset, start the patient on steroids. Do not hide away from anticoagulation wherever it is required. I think in saving these patients, hit hard, hit fast, that is something that works. And in our practical experience, I think the patients where we are not able to salvage them, those are the patients who have been referred probably from peripheries. The patient have been hypoxic for a very long period of time. The patients have not been given the correct doses of steroids. And I think everyone needs to probably, in this disease where we do not still have the panacea, we do not have the exact measurements, the exact treatment available, one needs to hit fast, hit hard.
Thank you, Arjun.
Arjun, if I could, give a comment. For steroids, you don't have to wait for hypoxia. If the
Yeah,
CRP is high, if there's a pneumonia, go ahead.
exactly, sir. Exactly. So one should not wait for things to
Wait
actually
for.
become really
So
bad.
I'm just, so adding to what you are saying.
Yeah.
So can I say something?
Yeah, please go ahead.
So every time I do a webinar, I learned something. So today also I've learned from both of you, and I'm being very honest from core of my heart. It has been amazing listening to both of you. So thank you very much.
Well, thank you, Dr.
Always a
Pilani. Needless
pleasure
to say,
listening to you, sir.
a person like you brings in so much wisdom and so much experience. So
No,
it is
experiences with Arjun. They go inside. I don't go inside.
invaluable having you in the forum. It is a privilege to have you in the forum. As also
No,
Arjun, you wanted a youngster, and you indeed brought the youth and a lot of zeal into this presentation. Thank you so much. So both
Thank you.
of you are responsible for making this a very engaging session. Actually, given the chance, we will be kept here with more questions. Unfortunately, good things have to come to an end, and that's why we are drawing to close. And I want to thank the Abbott team
yes,
for
yes.
having invited us for this session and having conceived of little out of the way in focusing on the management of mild to moderate cases. Thank you, Dushyant and team, that you brought this useful educational event for a lot of
Yeah.
doctors.
And
Thank
I
you very
must
much.
say that the Abbott has kept very high morals and high ethics in conducting this meeting. So, no banners, nothing. So that's
Yeah.
thank you, Dushan, and thank you, Bhaskar, who has been chasing me.
So, you can't get a better compliment than that, Abbott team. I think very well deserved compliment, and thank you. And
Absolutely.
finally, we have to thank all the people who
Who have
patiently
attended.
walked in and have followed this, asked a lot of very important, interesting questions, which actually engaged us, and we have been learning, trying to answer these questions. Thank you so much. And all of you stay safe. And of course, and before I hand over to Dushyant, I just want to say, please stay safe, stay healthy. This applies not just to you, to all your family members and people around you, and of course to your patients as well, who depend
Sure.
so much upon you. And be an instrument of healing to the community. And with God's help, let us do what we can. Thank you, Dushyant. Over to you.
So thank you, sir, and thank you, Dr. Khanna and Dr. Khilnani, for such an enlightening and such an informative panel discussion. And it was an indeed pleasure. And our sincere gratitude to each one of you for sharing your experience and clarifying the doubts of the live audiences. I sincerely hope that everyone out there would have some meaningful learning out of these three talks and the panel discussion. And
Yes, and
we would be looking forward for such kind of healthy interactions in future also. So thank you all. I thanks each and every person who has joined us live during their hectic schedule on this Friday evening and being a part of this live webinar. So thanks all of you for joining us and asking your queries, and I hope that it has been answered. But as sir rightly said, that good things come to an end, so we are closing the show. And thanks to the commercial team and thanks to marketing team for putting up this great show. And I also thanks our DocMode team, the technology partner, who give us this platform to do a smooth transition and without any glitch. Finally, we have one unglitch event which has happened today without any glitch, sir. So thank you, DocMode. And with this, I would just like to wind up the show by saying that namaskar and stay safe and stay healthy. Thank you, everyone.
thank
Thank
you.
you, everyone.